All right, welcome to the show. I'm your host, Dr. Koppas, and I'm joined by my guest today, Dr. Charles Shidlofsky. You are in Austin, Texas, is that correct?
No, Plano, Texas.
Plano, Texas, that's right. Well, thank you for joining me today. Can you tell us a little bit about yourself and then what it is that you do?
Well, technically, I guess you could call me a neurodevelopmental optometrist. So I work with a wide range of patients, but all specialty patients. So the first group of patients I work with are pediatric and developmental cases such as autism, ADD, ADHD, dyslexia, genetic disorders, really anything in that realm of people having some difficulties with visual processing. Strabismus and amblyopia are some of the visual issues that we work on also. So those are one group of patients. The second group of patients we work with is going to be your traumatic or acquired brain injury patient. So and we're on staff at several rehab hospitals here in the Dallas area. But basically we're talking about stroke, concussion, traumatic brain injury patients. The third group we work with are athletes. So we work a lot with several sports teams in the area, but we also work with individual weekend athletes as well. But here in the Dallas area, we work with the Dallas Stars. We work with a minor league team called the Allen Americans, and we work with FC Dallas. Of course, no one's playing sports right now, so I'm not working with anyone right now on that. Right. And then lastly, one of probably the newer areas, or it's been an area I've been doing for a while, but it's really just kind of hitting a mainstream right now, and that is myopia management. And that's where we take children who are developing nearsightedness and try to slow down the progression of the nearsightedness.
Okay. So I feel like we have a lot to talk about today and a lot of stuff to break down. So, but before we get too deep into all the specific categories of patients that you work with, can you tell us a little bit about yourself as far as what got you interested in this particular type of patient care?
Well, I think really what got me interested into it years ago, I had visual processing problems, but it wasn't identified actually till I was in my first year of optometry school. And I was in the lab, and we were examining each other, and my lab partner said to me something about, hey, there's something weird going on with your eyes. And the professor came over and said, son, you're going down to the vision therapy clinic this afternoon and getting an evaluation. And I said, what's the vision therapy clinic? so that's how much I knew about it. Mm-hmm. But I learned a lot and really just kind of worked on myself, when I was in school. And then when I got out of school, that's really where I had the opportunity to really figure things out about visual processing and its importance. Because most people, when you go to the eye doctor, what do they think about? They think about what's on the eye chart. Can I see 20/20? Eyes are healthy. Have a nice day. That's pretty much the exam. But obviously, there's so much more to visual processing than just those few elements. And that's really where I got the bug to really kind of go in this direction and working with all these different types of visual processing issues.
Very nice. And the first category you mentioned was the Neuro-developmental Optometry and the work you're doing with that population. What sets your approach apart from maybe some other things that are out there? How are you approaching these cases?
Well, obviously, what we want to do is, number one, we want to identify what the problem is. Okay, so we're looking at things like what we call accommodation. That's the ability to go from distance to near to distance, smoothly, efficiently, and accurately. We want to look at eye tracking. We want to look at things like convergence and divergence, how the systems work. We also want to look at visual spatial skills. So the vision system has to answer three questions for us. What is it we're seeing? Where is it in space? And where am I in space? And what we found out is that a lot of these kids we work with, a lot of these adults who've had traumatic brain injuries, guess what? It's the third question that's really the problem. Where am I in space? They don't know where they are. And so So when you investigate those aspects of the visual system, you're going to get cues and clues as to what's going on, and then you can come up with a treatment regimen. And the treatment regimen may look like something we call. There's really two types of treatment regimens. We can look at what I call passive therapies, which are like lenses, prisms, tints, occlusions to create a therapeutic change. And then active therapies, where they come in and work with our therapists and work on enhancing, or really what I call breaking the old bad habits, developing the new good habits. So that's largely what we try to do as far as that goes.
Very nice. And those patient populations that tend to fit in this category again were you mentioned, I think, ADD, autism, etc.
Right. It's interesting. I started out really intrigued by ADD because I have it myself. So I think that's what caught my attention first. And there's a few things I figured out with ADD early on. And and the big question that came to me is, why do these kids with ADD? Why could they can't read for 5 minutes, but they can play video games all day long?
Yeah.
So I started thinking about it from a visual standpoint. What's going on visually that's different between in each of these situations? And so for the book, they're looking at black and white, they're looking at high contrast, they're looking at a stable static image, if you will, and then they're just moving their eyes across the image. There's no real stimulation to the system. But when you're playing a video game, you're looking at something centrally, but you're being aware of periphery. Okay, and so really what I started realizing pretty quickly is it's the periphery that really is where things are at. When you start, if you can start to analyze what's going on in the peripheral visual system, that's going to tell us the most about their visual processing. So I started saying, how can I impact the periphery? Because all optics, or most optics that we knew about at the time, impacted central vision, once again, to bring about 20/20 vision. So that's one thing I realized, and it really maybe answered another question for me, because for the life of me, I couldn't figure out why we would give a hyperactive child a stimulant. Yeah. And understanding what I understood about how the visual processing system worked, I realized what's happening there is that what ADD it truly is understimulation. What we do to act out, our behavior is a way of self-stimulating. Okay, so what a stimulant does is it stimulates without having to do the self-stimulation. Does that make sense? And so that's when I realized that. Then I said, okay, what else? What else is going on? That's affecting peripheral visual processing or temporal vision processing that's getting in the way? And so slowly got into that. Then later on, quite a bit down the line, I got called by a rehab center and asked me, hey, can I work with brain injury patients? I said, I haven't, but I'll figure it out. And really applied a lot of the same concepts to that population. And, now it's about half of what I do every day.
Okay. So you began with more the neurodevelopmental side of things, and then you were able to actually apply a lot of those principles to acute brain injury.
Exactly correct. Interesting enough, I was also very involved in sports vision when I was in optometry school. And really, that's really where I wanted to focus my therapies at. But it was such a poor market and a poorly understood set of skills at that time. But really what got me back into doing sports vision again, interesting enough, was concussion. Because because I developed this expertise in neurological injury and concussion, that's when the sports team started approaching me and saying, hey, I heard you do some great work with concussion. And I said, yeah, but we also do visual enhancement too for your athletes. Yeah. And so that kind of opened the door again to something I really love to do.
So what are some of the visual enhancement types of therapies that you're doing with patients? Does it involve like visual processing speed, things like that?
Oh, absolutely. I mean, you got to start at the basics, and really, the first level of things that I do are what I call visual vestibular grounding. The vision system and the vestibular system are really neurologically linked and neurologically tied together. So I have to make sure those two systems are integrating with each other. So I work on a lot of vision and balance activities to start with. Then I'll start strengthening each eye individually. Okay, I'll strengthen the right eye, strengthen the left eye. I'll start getting the eyes to talk to each other a little bit more. Then we'll start really working on binocular vision skills, and then ultimately perceptual and cognitive skills.
Mhm. Very good.
This is why actually frequently when I lecture and I talk to people who do some vision work, and a lot of people, especially who do brain injury, they start out with Brock string,
Mhm.
which is the string with beads, or they start out with pencil push-ups, and that's at the third level of what I just described.
Yeah.
And that's why it's a very poor choice for therapy for a brain injury patient particularly, but really for any patient, it's a poor choice of therapy when you're starting out,
Mhm.
because you haven't really built the foundation of good vision skill to build to utilize that skill. And while they may look like they get better, they really don't. You're just changing. It's like akin to going to the gym for 6 months and sitting on a couch for the next 6 months.
Mhm.
Okay, all you're doing is you'll look better, but all of a sudden you realize you're not that much better.
Absolutely. So, in your office, what are some ways that you're using to assess each individual patient to kind of determine where they're at as far as, determining how far along a patient might be post-injury or in their development?
Well, I think what it comes down to is we'll do a very comprehensive optometric evaluation, obviously, to look at those skills we talked about, accommodation, binocular skills, things of that ocular motor. And then we'll do what I call, we'll bring them back to do neurosensory testing. Neurosensory testing, sometimes when I explain to patients, like I said, it's kind of digging down the rabbit hole. You've figured out what the problem is. Now you want to dig down and kind of really get to the meat and potatoes of what's going on. So we can do things like something that's familiar to a lot of people is called something called right eye, which is an electronic eye tracking test.
Mhm.
We'll do a cognitive test. There's all sorts of cognitive tests out there. I've used Impact, Mocha. A new one we're using right now is CogniView, which I like a lot. So these are some of these tools that we can use for cognitive. I'll do balance testing on almost every patient. Okay, I'll put them on do posturography, if you will. I'll do a modified CAT-SIB on everybody. But the difference between way I do a modified CAT-SIB and others is I'll do a modified CAT-SIB baseline, and then I'll add different types of therapy type lenses on top to see how I alter their balance just with lenses.
Mhm.
So I can utilize that to help me determine what lens is the proper choice for an individual.
Absolutely.
Um, so those are some of the different things that we can utilize as far as that goes. We'll do visual potential. We'll do all sorts of perceptual testing.
Mhm.
We use something called motor free vision perception test, which we can utilize or to test the visual perception skill to look at visual perception skills. So we're really getting a big book, if you will, on all their potential vision skills and their impact to other things. Obviously, a big tool in our toolbox is when do we refer?
Mhm.
Okay, so which is always a big question, and obviously we're going to look at the problem set and say, okay, are we the best person to see this patient right now, or do they need to go see somebody else at this point, and then come back and circle their way back to me at some other point?
Yeah.
So so that's also a big piece of the puzzle, is figuring out all those little elements.
Okay. So, in a perfect scenario, who is, I guess, the perfect patient that really fits into your care that you provide, that you really, love to work with?
Oh, I don't think I have a perfect patient. I have a lot of imperfect patients. I think that's probably the better answer to the question. Anyone who is having, you know, from kids, if they have, they fall down a lot, they bump into things. Adults, same thing, falling and bumping into things, not being aware of their surroundings. Kids who can't ride their bicycles because they can't visually process that. Difficulty reading, difficulty writing. Obviously, anyone who's had a concussion, anyone who's had any type of traumatic brain injury. Interesting enough, a lot of the concussion patients I'm seeing a 1 year, 2 years, 3 years post concussion. And
Mhm.
they're really, I guess you can call them post concussion syndrome. But usually I'm virtually one of the last people they get to see, because they've been to the neuropsych, they've been to the PT clinic, they've been to the OT clinic, and they're still having visual processing problems. And finally someone says, well, maybe we'll send them and check on their vision, surprisingly enough.
Hmm.
So anyway, that's kind of how it goes from there.
Okay. Um, so,
Keep going.
okay. You had mentioned uh, prisms earlier in the interview. Uh, can you speak? A lot of patients that we see often, use prisms from their neuro-optometrist after concussion. Can you speak to kind of the length of time somebody should expect to wear a prism? Is this something that you want them to be wearing indefinitely, or is this something that you want to rehab and eventually, not use anymore?
Good question. There's two types of prism. Let me start with that. There's your traditional orthoptic prism. That's if you have a person who's had cranial nerve palsy and their eye may turn up or down or in or out. Those type of prism lenses are what we call orthoptic prism. They're designed to move the eyeball. So they really work, if you will, on the musculature of the eye. In those cases, prism may be permanent, but we may lessen it over time also. It just depends on the situation. The common type of prism that I use, probably more than anything else, is what I call a neurotherapeutic prism. It's a very special application of prism, and what we're doing is expanding space. We're opening up visual space, and those type of prisms are temporary. We may use them for 6 months, a year and a half. It just depends on the patient. But those are what we call therapeutic in the sense that they change the neurology, they change the brain, they change they make new neural connections, help make new neural connections. So when we're changing the brain, ultimately we don't need the lenses anymore because we take on the effect of the lens. So they are more short-term in nature. Sometimes, though, we will combine the two together. If they may have had a cranial nerve palsy or something of that net, but they also have they also have a spatial inattention or spatial collapse, and we need to address that, and then we can do a combination lens, in which case we might reduce part of it and not reduce the other part of it. So it just depends on the situation. But there's many uses of prism. So we can't think of prism in a solitary sense. We have to think about it in the fact that it has multiple uses, just depending on how we use that particular tool in our toolbox.
Mm-hmm. A concept that we often talk about on this show is neuroplasticity. And listening to the way you're speaking of kind of how you approach your patients in the clinic, it sounds like you may utilize that concept as well. Can you speak on that? Not to put words in your mouth, but is that something that you consider in your office?
Well, absolutely. See, neuroplasticity is the whole reason a therapeutic lens works. Mm-hmm. Okay. Once again, you're creating new neural connections. You're changing the brain. Ultimately, that's why it works. I'll go back to the example I gave a little bit earlier. I said if you go ahead and do pencil push-ups and you do Brock string on a patient and you haven't built it up, all you're really not changing. You're not using neuroplasticity in a case. You're changing muscle. Okay. If you think about it, when we build it in a particular way, we build up the visual system from foundation on up. I mean, how would you build a house? You build the foundation, you build the scaffolding, you build the house, you take down the scaffolding. You have to build it in that way. Then you're going to change the neural connection, right? Right. And just like the example I gave, if you go out and work out at the gym for 6 months, then you go sit on a couch for 6 months, your muscles are going to go to hell, right? But if you work out and you change your brain chemistry and you continue that process and you continue working on the things that you've been working on, you've made a permanent change in that neurology. You made a permanent neurochemical change, if you will, and obviously change that brain's plasticity now to a point where that change is going to be more permanent.
Mm-hmm. Absolutely. And I'm glad you mentioned, really, making sure you approach the foundation of the issue before you jump right into maybe something that's stronger, like Brock bead exercise. Right. And something that is foundational to the nervous system is the vestibular system, which you had mentioned earlier. In what ways are you using to integrate the vestibular system and the visual system, or is this something that you like to co-manage with, say, a vestibular therapist or someone else?
Well, there's a lot of different elements to that, so I'll try to break it down. As I
Mhm,
said, that's the basis of that is my foundational skill. I call
mhm,
it visual vestibular grounding. So to me, it's very important. Now, if they have significant vestibular issues, the first thing I'll do is I might refer them to a vestibular specialist and work through those skills, because I can work all day long in vision and nothing is going to change. Nothing significant is going to change. So I've got to make sure a lot of the vestibular issue is out of the way. But if they're having a visually charged vestibular issue, in other words, the vestibular issues coming through the visual system, they have a lot of motion sensitivity, they have a lot of things like that. That's where we can just attack it right away, and we'll go right in and start working on that visual vestibular grounding to stabilize that system. And there's all sorts of tools we can use. We mentioned therapeutic lenses. There's another tool we talked about where we actually do some occlusion, special types of occlusion on the lenses to help use as a filtering system, so that we get a lot more visual stability as well. So, as I said, multiple different tools. We talked about a few, but once again, we have to figure out what's going to stabilize that visual vestibular picture, because as I said, they're inexorably linked, which is why I do balance testing on every patient. I got to see where their balance system is. If I can impact that balance, I can measure and in a measurable way, then I can really, that's something that we can jump right into.
very good. Very good. So let's take an example of say I have a concussion, or I have a child who has a neurodevelopmental problem, and I want to seek care in your office, just so our listeners have an idea of what to expect. So I go to you, we go through this in-depth examination that you described, and then what does the therapy schedule, or what does the therapy look like with you? Can you give us some examples or walk through?
Yeah. So, when we do the consultation visit, we go over all the test results. We might recommend passive therapy, which we talked about before, which is lenses,
Mhm.
prisms, tints, occlusions, and or active therapy, which is where they come and work with our therapists, and we have all
Mhm.
sorts of different tools for that. I'll jump into that in a second, or a combination of passive and active therapy as well.
Mhm.
So active therapy, we might do. We might do things like we have a whole therapy gym. We have a swing. We have balance boards. We have walking rail. We might put them on the walking rail with high-powered prism lenses on there to help expand space. Okay, to make them more aware. We'll do a lot of peripheral vision activities, looking at a board, doing things out in the periphery, bringing it to the peripheral to central,
Mhm.
so that they develop their good peripheral vision skills. We have tools that utilize virtual reality that really work on opening up the periphery, so they're more aware of their periphery. We have a product called Bonovi Touch we use here in the office. It's basically for if everyone's ever seen those light boards. It's basically a tactile induced light board where lights will go off. You hit a button on the screen, and then you go to the next light, then you go to the next light, then you go to the next light. And I might start off with them just on the ground doing it, and I'll work my way up to their work doing it on a balance board. Okay, I have a lot of different activities where maybe the flashes get faster, or I might do a near far activity with it, or I might do a go no go activity. If it flashes green, you press the button. If it flashes red, they don't press the button.
Mhm.
So all sorts of different tools that we can utilize to help, once again, that develop that central peripheral enhancement utilizing balance. So it's really, that's really, as I said, such a big part of what we do is really from that foundation, from the very outset, is to really build that relationship between vision and vestibular.
Yeah, that's fantastic. It sounds like you have a lot of great tools at your disposal in your clinic.
Uh, Everyone calls my office the toy box for a reason.
That's great. So I wanted to budget, we're just about out of time, but I wanted to budget just this end part for you to leave our audience with any final words, any final thoughts that you might have. Yeah.
Oh, absolutely. Well, as I said, there's a couple of great organizations that I'm part of in a very intimate way. Obviously, as an officer in three particular organizations. One is called the Neuro-Optometric Rehabilitation Association, and it's an outstanding organization. It's a multidisciplinary organization. All three organizations I'm going to talk about are multidisciplinary. Um, if you go to the website noravisionrehab.org, Nora visionrehab.org, take a look at it. Some great information on neurological vision processing issues. We have a meeting every year in September. This year it's going to be in Columbus, Ohio, as long as this virus goes away. And it's going to be in Columbus, Ohio, mid-September. Once again, we always have several chiropractors and functional neurologists there. Actually, one of the original board members was a chiropractor.
Oh, really?
And so that's really an outstanding group of people. The next group I'm going to talk about is IAFNR, which is the Functional Neurology Association, and I'm actually on their board. I work a lot with many of the functional neurologists around the country, and do some consulting. It's iafnr.org. And then lastly, I'll talk about the International Sports Vision Association. Obviously, with my interest in working with athletes, this is an organization that I'm actually a founding member of, one of the three founding members, and we just had our fourth meeting in February, and it was really outstanding. We had a lot of great speakers, and this is really for those who want to work with athletes in sports. And once again, it's an interdisciplinary organization. We have athletic trainers, we have chiropractors, we have optometrists, we have MDs, we have all sorts of people from different fields, neuropsychology, that participate at that meeting. And that meeting has grown, it's doubled in size every year. We had over 200 people at our meeting this year in San Diego. So it's really grown a lot since day one, for sure. But also, if you want to get in contact with me, my office website is neurovisionassociates.com. Neurovisionassociates.com. If you want to use the short version, there's a short version. It's dr-s.net. So I have really two versions of it. Sometimes it's easier when I'm saying it to just use dr-s.net, but it'll get you to the same website. It tells you a little bit about what we do. Has some links on there for you as well. But certainly, if you want to reach out, you can always reach out to me through that website as well. So I just thank you for having me out and talk about some of these things, and glad to answer any questions.
Yeah, I really appreciate you coming on and sharing your perspective and your particular expertise in this field. I think our audience is going to get a lot out of this particular podcast. So thank you.
No problem. Have a good one. Everyone stay healthy.
Yeah, that's important right now. So from your host, this is Dr. Kappas. Be well.